Good morning, everyone. Welcome to September again. This is our second grand rounds in our series for Women in Medicine Month. We're lucky and blessed to have Dr. Keisha Ray joining us as our speaker. Before she is introduced by Dr. Tabor, I'd like to pass it to Dr. Dunn for announcements.
Wonderful. Thank you, Dr. Harmon. Good to see everyone on the second Wednesday of Women in Medicine Month. And speaking of Women in Medicine Month, it's our picture day today. We will have two opportunities to have your picture taken, one in person, which is going to be our annual group photo at 12 p.m. right in front of the Clark Center on those steps. As you can see our picture there on the left from last year. And then there's also going to be an opportunity for a virtual photo today at 4 p.m. on Zoom. If you could make both of them, it'd be fabulous. Remember to wear red, wear your white coat, and come with lots of energy. It'll be great to see everyone in person. A reminder that we will be screening Ms. Diagnosed, I hope Dr. Colton can hear me. That will be coming up on October 4th. And if you recall from last week, Ms. Diagnosed is a film about women's health and the fact that women present differently than men. And so many diseases are only studied on men by men. And this follows the story of three women who were misdiagnosed. And we're going to have 1 week of availability of this film. And then we'll have a panel discussion by two of the filmmakers, Q&A that will happen on Wednesday, October 4th, virtually at 12 p.m. So put that on your calendars, please. And we will send you the link to the film on September 27th. As I mentioned, we'll have an entire week to watch the movie as a community. And lastly, an upcoming grand rounds by none other than Dr. Caroline Berube. She will talk to us about innovations in hemophilia next week at this time. And with that, I will pass it over to Dr. Tabor to introduce our speaker today.
Great. Thank you so much, Dr. Dunn. It gives me just the greatest pleasure to introduce my colleague and friend, Dr. Keisha Ray. Professor Keisha Ray received her PhD in philosophy with a focus on bioethics from the University of Utah. She is currently a tenured associate professor with the McGovern Center for Humanities and Ethics at UT Health Houston, where she also serves as the director of the Medical Humanities Scholarly Concentration. Most of Dr. Ray's work focuses on the effects of institutional racism on Black people's health, highlighting Black people's own stories in Black health discourse, and the social political implications of biomedical enhancement for marginalized populations. Her work uniquely prioritizes simple language as a matter of access and justice. Dr. Ray serves as the associate editor for the American Journal of Bioethics and the media editor for its blog site, Bioethics Today, to which she is also a regular contributor. She has contributed to top clinical, bioethics, and medical humanities journals. And based on her expertise, Dr. Ray is also frequently called upon as a bioethics expert for popular news sources. And lastly, but definitely not least, Dr. Ray is the author of the book, Black Health, the Social, Political, and Cultural Determinants of Black People's Health with Oxford University Press, which is just a fantastic book that I read and enjoyed and look forward to teaching with in the future. So we are so excited and grateful to have Dr. Ray here today. Thank you so much. Take it away.
Thank you. I appreciate it. Thank you for the invite. And I'm super excited to be here. So let's get started so I can make sure I can get through most of the slides. Let me go ahead. All good? Thumbs up, Dr. Tabor? Got it. Okay. So hello, everyone. So like Dr. Tabor said, I am Keisha Ray. Please feel free to call me Keisha. So I'm going to talk a little bit about the work that I do with health equity and anti-Black racism in health and healthcare, and talk a little bit about bioethics. So the central question behind my presentation is really, what can Black Americans' health tell us about what a more equitable access to healthcare should look like? And I know health equity has been one of those buzzwords lately, especially during the pandemic. And so I hope to talk a little bit more about what that means. And then hopefully in Q&A, we can talk about some other conceptions of that term and what you all take it to mean. I start almost every single presentation with this chart because it really sets the background for how I think about Black people's health. I try to focus on the social determinants of health. And one reason why I do that is really because at the beginning of me doing this work, I started off, some years ago. A lot of times, a lot of the pushback that people in audiences or on Zooms would give me would be, why aren't Black people doing better for themselves, right? They wanted to make poor health an individual issue or an issue of irresponsibility or even a moral issue, right? You're not being a moral person, you're not doing something right, and that's why you have bad health. And I wanted to make it clear, and just as I will today, that people can make bad decisions about their health. Black people can too, just like anyone else, right? I don't want to take agency away from Black people, but at the same time, we have to look at the context of those decisions. You can only make the kinds of decisions that your environment allows you to make. So the social determinants of health sort of give us this broader picture of these social, cultural, political, and commercial influences in our life, like income, housing, literacy, whether you have access to healthy foods, stressors, policing, and then also access to healthcare. You can only make decisions about your health that are good decisions insofar as you have access to these social determinants of health. And even when you try to make good decisions about your health, the social determinants of health still can influence your access to making those good decisions. So if you decide, I'm going to go running every day, I'm going to do this for my cardiovascular health. But if you live in a neighborhood where you feel unsafe, if you live in a neighborhood where there's no sidewalks or there's potholes or the air is polluted, then even if you do have the time and the resources to go running, these other influences that are beyond your control can still influence your health. And so for me, it's about who has access to social determinants of health and who doesn't. And as you do more and more research with social determinants of health, you start to see that access to these factors do fall along racial lines, they fall along class lines, and there's other lines, but those are the two that I'll focus on today. But this handy dandy chart I won't go too much into because I'm sure you've seen at least one like it before, if not this exact chart. But it's just enough to say the more access you have to the social determinants of health, the more likely you are to have positive health and well-being. And again, I want to focus on health and well-being, not just health care. And so when we talk about racial disparities in health, that's another phrase that you'll see often. And I sort of hope that people, when they see this, are really thinking about racism, like racism's disparities in health, and thinking about racism's impact on health and the prevalence of disease. So when we focus on things like life opportunities, exposures, and stressors, that those fall along racial lines, and that then contributes to differences in health outcomes. And so that's really what you see when you hear people talk about racial disparities in things like cardiovascular disease diagnoses and therapies, leg amputations from disease complications, breast cancer related deaths, pain management, birthing mortality, infant mortality, and just general mortality. When you hear people say Black people die more from these diseases, or Black people have higher rates of complications from these injuries and diseases and ailments than other races, what they're really saying is that because of racism's impact on health, they have a higher prevalence of disease. And so this is one of those terms, again, that you see sort of thrown around, but needs a little bit more explanation. And so say all this to make sure we're on the same page. Also, as I'll talk about in this conversation that we're having, is that it's not by accident that we have racial disparities in health. It's not by accident that Black people have lesser access to the social determinants of health and therefore lesser access to positive health outcomes. It's historical, it's social, it's political, and all of that together reflects a contemporary racial disparities in health. So the way that my presentation is broken up into these two various sections right here. So first, I'm going to talk about how anti-Black racism in our social lives create patients and give you an example. And then I'll talk about how anti-Black racism in our clinical lives prevents people from engaging in their desired social lives. So where you can start with the social determinant of health, or you can start with the health outcome, but you can still see some anti-Black racism in there. And then that prevents Black people from having well-being. So the first example I'll talk about is anti-Black racism in our social lives and how that creates patience. So first, let's talk a little bit about housing. Housing is, if you can have a favorite social determinant of health, is that just like a nerd thing that people who work in this area have a favorite social determinant of health? Housing is mine. There's a lot of great books out there, like The Color of Law, that are written about the history of housing in the United States and how it's a foundational in anti-Black racism. So we see things like discrimination in housing loans, where Black people are were less likely, and they're still less likely to get housing loans. We see in the history of redlining, where literally put a red line on a map and put where Black people can live, where white people can live. And then also that means where resources are and where resources are not, or where things like money for schooling or money for recreational areas like parks are and where they're not. We also see discrimination in GI Bill benefits, right? That after serving the country, that we had soldiers coming back to the US and they were promised that you would get money towards housing, but we saw that when Black soldiers came back, they didn't get those benefits. And so because of that, when people don't have access to housing, they can't buy homes, they don't get the generational wealth that comes from homes. A lot of times you have people that were able to take mortgages out, but then also to take second mortgages out to put their kids through college. And then those kids would go off to college and then we're able to take care of their parents. But if you don't have access to housing, then you don't get the generational wealth that can come from homes. We also know too, which I'll talk about next, is that pollutant emitting facilities like oil and gas companies, and I'm in Houston, Texas, so that is a dime a dozen here, right? That they're disproportionately built in their Black, Latino, Indigenous, and poorer communities. They are not built in wealthier neighborhoods. They are not built near predominantly white neighborhoods, partially because of political power to make sure that doesn't happen. But then also companies know that they can't get away with it, right? So next, talking about how where you live matters. And we all know the example of Flint, Michigan, right? What's interesting about Flint, Michigan and their water crises is that 2/3 of Flint, Michigan are Black people. About 75% are classified as having low incomes. And yet, till this day, and now this was about maybe 10, 15 years ago that the crisis was first brought to our attention, there's still a lot of people who don't have safe water. They turn on their faucets, it's still foul smelling, it's still brown. So this is an ongoing issue. Flint, Michigan and their river and their water situation did not end. And if you aren't familiar with it, Flint, Michigan had polluted water from pipes when the city decided to change its water supply from Detroit supplied water to the Flint River. There was also an outbreak of Legionnaire's disease that was disproportionately affecting Black people, in particular Black children that were getting sick, and some died. And so this is just one example of how where you live can influence your health. Another issue that you may have seen is Cancer Alley down mostly along Mississippi and Louisiana. Louisiana's Cancer Alley is called this because there is a string of oil refineries, companies like ExxonMobil and Shell, they all have different refineries in this area. And this area is predominantly Black. And now in this area, in the late 80s, early 90s, these companies were selling homes in these areas specifically to Black people and marketing as getting a piece of the American dream, right? That you can have an affordable home in this area. So come here, we will give you mortgages, we will give you homes that you can live in. All the while knowing that these homes were built on top of toxic landfill. All they did was put that kind of Black netting. If you're a gardener or you're trying to stop weeds, you know that kind of Black netting that you put on top of soil. And then they said, problem fixed. There's no issue with toxic soil. And then all of a sudden, their cancer rates in this area started being 200 times the national average. People here were having mysterious illnesses that they could not figure out what the cause was. You had entire families and entire streets of people who were dying of cancer. And then you started having these sort of like ghost neighborhoods because everyone was dying. And right now, if people don't have a lot of political recourse, there's been a little bit of talk in the last couple of months about having some allocation of money for these people, but it's not enough for them to move. They can't sell their homes because who wants to buy these homes in these areas? And so again, these are predominantly Black neighborhoods, with residents who are being subjected to this kind of pollutants. And now why this matters is, sometimes I sit in my office like with the red yarn and I'm drawing connections and I feel like a mad woman, because if you look at it, what this all says to me is our social and our political lives are so intertwined that they affect our health. And one example from all of this talk about environmental injustice and housing, one example that I think is really heartbreaking for me is the example of Black adolescents, in particular, Black adolescent boys. So Black boys, for instance, are one of the most vulnerable subpopulations in Black communities. They have very, very high asthma rates, along with Latinx boys, but Black boys are a little bit higher, but they have almost 10 times as many hospitalizations for asthma than white children, and about 3 times the rates of deaths from asthma-related injuries. And then additionally, when you look at the COVID-19 death numbers, you see that among US children, Black children, particularly Black boys, have the highest rates of deaths from COVID-19. And for me, none of this is accidental. Like I said, none of this is just can be looked at individually. If we're going to have a good picture of Black health, we have to look at them all together, how these social and political issues affect health. And then when we look at COVID-19, it's not by randomness that Black boys who have higher rates of asthma who are also have higher deaths from COVID-19. And so again, you have to get this full picture. And then the point for me is that our health is tied to our environments, to that. And remember, environmental safety, access to clean air and clean water is a social determinant of health. If you don't have those, then you can't possibly have health. And so this handy dandy chart of how I look at it is, if you look at the left side of your screen where you have housing and environmental racism are connected. Where those oil refineries, where the toxic landfills, where you have those small particles in the air that get into your lungs that can cause cancer are connected to where people live. Who experiences environmental racism is connected to the people that live around these facilities. And then you have this connection between asthma. So when you start with the social determinant of health, and then how an inequity in that social determinant of health gets manifested, we can see that in environmental racism, and then we see the negative health outcome, which is asthma. And so this is just a very simplified way of how all of these red yarns and all these connections in my brain work. I tried to make it as clean and not messy for you all as I possibly could. So let's look at example 2. So in this example, I want to show how anti-Black racism in our clinical lives prevents people from engaging in their desired social lives. So this sort of turning the last example upside down. So let's talk a little bit about pain management, which I know some of you probably know the basics. You know that Black people get less pain management in clinical settings than others. But let's talk a little bit about why that is. So we know that the features of a person can send cues to clinicians about their pain levels. And we know that a lot of those cues are amoral features of ourselves. Sometimes people's skin color, if they look disheveled or not, if they look like they're in pain, right, whatever that may mean. How they're dressed. If they're dressed too nicely, they can send a cue that you're not in that much pain because you could take the time to dress nicely. And so we know that there's a lot of cues that clinicians take in about a patient when they're deciding whose pain is real, who's actually in pain. And we also know that it can lead to a lack of urgency in pain management and pain care. We also know about perception of drug-seeking behaviors, right? I don't really like that term, but that's what it's called in the literature. We know that that can fall along racial lines, that Black people, along with other racialized minorities, are seen as having more drug-seeking behaviors than other people. And we also know that intersectionality plays a role in whose pain is taken seriously. Think of like Black men, and cardiovascular disease, their pain or their complaints of chest pain are generally taken less seriously. We know the research about Black children and broken bones out of Atlanta, that they're giving less strong pain management than white children with broken bones. So let's keep going. So let's talk. I'm gonna tell you just a few studies so you can kind of see how this plays out in the literature. And so there's a lot of literature about non-definitive conditions and definitive conditions. Essentially, what they're finding is that if a clinician can have a diagnostic test and it says this person has this disease or illness or some kind of, there's just something improperly functioning in their body, then clinicians are more likely to give them opioids during the emergency department visits because they have what they call, definitive proof, essentially, that this person is in pain. But when there's non-definitive conditions is when they're less likely to get it. But when it's definitive conditions, like a kidney stone, they are more likely to get opioids. Excuse me, I messed that up a little bit. And so in other words, it's trusting the test over the patient, right? I need the test to tell me to support your cries of pain. I need the test to prove to me that you're in pain, and then I'll believe you and give you stronger pain management than if the tests don't prove it. So if you come in with like abdominal pain and there's no diagnostic test that's proving it, even if they even do any kind of diagnostic testing, is also falls along racial lines. Another study that I go back to a lot in my work is this huge VA hospital study of opioid monitoring. And it was massive. It was over multiple veteran affairs hospitals. And again, these are veterans that we're talking about. And researchers found that when Black patients compared to white patients, that Black patients were monitored more closely and more frequently urine tested to see if they were abusing their opioids. They were suspected of drug abuse more and sent to drug counseling more than white veterans. They were more often denied opioids altogether, and then more likely to be given opioids while in the hospital, but not for a prescription when discharged. So again, that tells me they're more likely to give opioids when they can be monitored, right? And where they can be trusted because they have monitoring, rather than at home where they can't be trusted because they don't have anything monitored. And what, always I try to point out with pain is that's something that we throw around, but pain is very serious. If you've ever been in pain, if you've ever had chronic pain, you know that it can be financially taxing. It can be emotionally taxing. It can be mental. It can take a toll on your family. It can take a toll on your view of yourself. Maybe you can't participate in your hobbies. You can't play with your children. You can't spend time with your partner. You can't walk your dog. You can't play with your cat, right? Pain is a very real thing that affects the quality of our life. And so when I hear about people being left in pain disproportionately, it is extra it's extra sad to me because it's this extra burden that we're placing on people because of skin color. Another study that I want to briefly talk about is this racism and empathy for pain on our skin. So in this 2011 study, white participants were shown videos depicting African, white, and Asian actors' hands being touched either by a pencil eraser or by a needle. And white people, the white participants, they had a greater reaction to the white people being touched by the needle than by Africans being touched by the needle. And so researchers, after going through all of this study, they concluded that, and I quote, "The extent to which white observers share the pain experience of other people is affected by the race of the person in pain." They also concluded that it aligned with what a lot of people call the dehumanization theory, or the theory that some social groups elicit less social emotions within us, leading us to think of them as less humans. So in other words, it's about familiarity. If it's people that we are familiar with that look like us, their pain affects us. We perceive their pain to be like our pain and want to do something, want to stop it. And so for me, this study is this example of racial disparities in pain management, but also this psychological reality that we connect with people who look like us, we feel their pain. And so if majority of our physicians are not Black, right? We have about 3% of our physicians that are Black, but a lot more Black patients than there are physicians. That seems to me that we can't do what we like to call race matching or racially concordant care, but that we have to think about how do we increase empathy with our clinicians? How do we have How do we say, just because this patient doesn't look like you, doesn't mean that they aren't in pain. It doesn't mean that their pain is any less significant. How do we get rid of that racial bias of people who cannot maybe racially connect with their patient, which should not be a prerequisite for believing someone's pain? The last study that I want to talk to you about is perspective taking. And I find this one super interesting as this sort of continuation for empathy in pain management and thinking about what's the root cause of racial disparities in pain management. So in this study, look at the control group. In this study, the nurses watched videos of real Black and white patients, their genuine expressions of pain. And then these nurses provided their opinions on pain treatment and reported their feelings of empathy for each patient. And you can see in this control group, there's a gap between the Black patients and the white patients that they feel empathy for. And then in this perspective taking one on the right, another group of nurses, they did the same task, right? They watched these videos of real patients, and then they were instructed to engage in perspective taking intervention, meaning imagining how the patients must feel, how pain affected their lives, like looking at this broader picture of pain, kind of what I just talked about, the toll that pain takes on a person's life. The nurses in the perspective taking group had an increased psychological closeness to the group of Black patients, and it diminished their group-based evaluations, right? They wanted to look at each individual patient and make recommendations rather than just saying all Black people X, right? And then you can see that Black-white gap, that disparity in belief or empathy for their pain also decrease. So this is another example of how listening, empathy, perspective taking can mitigate some of the implicit bias in pain management. I by no means am a believer that empathy is everything, and perhaps we can talk about that in Q&A, but I believe it can be a small part, but I don't think that that's the whole answer. And I also, wanted to make sure that I share with you my own writings about my own experiences with pain management. I gave this very short story, again, super short. There's like 2 takeaways after this for Clossler of Johns Hopkins. And this was about the time that I was on a vacation, experienced a lot of abdominal pain, ended up having to go to the ER. And my doctor was very short with me. I'll read a quick part of it. It says, he walked in, he said, despite the physical pain of his speaking, he asked me how many pregnancies have I had? And I said 0. And that took a lot for me to say that because I was in excruciating pain. It irritated, he rephrased his question. I don't think you understand me. I'm not asking how many children you have. I'm asking how many pregnancies you've had. And I can assure you that's almost word for word because this encounter with this doctor has not left my mind. And this was about 11 years ago this happened to me. And returning his irritation, because again, I'm still human. I was also irritated and I applied with, in the short tone, I understand your question. The answer is still 0. And then he said, well, but you're 26. That's surprising. Black women like you should have had pregnancies by now. And I just remember being stunned, but also in too much pain to even give him a piece of my mind. I remember putting my hand up to stop my mom, Black mother mama bear was about to say something to this doctor. I do remember having enough energy to stop her, but also because I wanted care. I knew that we needed this doctor in this moment. We can't be in here being the stereotype that he thinks of us anyway. I'm just focusing on how can this person help me, this clinician help me, which again makes me sad that I had to even think about controlling the situation when I'm in this much pain. We could talk about that later. So similar to the last chart, this one is just in reverse. So when we talk about health disparities that happen in a clinical setting, we can start with the health outcome, how that health outcome is manifested, which is control of opioid prescriptions, and how that leads to a social determinant of health, which is discrimination. Remember, racism is a social determinant of health because it's an act of discrimination, but also racism is seen throughout all of the other social determinants of health, like access to health care. And so in this situation, we can start with pain management. Think about how pain management, how those racial disparities are maintained, and that's through racial disparities in opioid prescriptions, and then look at the social determinant of health that it maps onto, which is discrimination. 3 more minutes, let's keep going. So now that we've talked about all of this stuff, right? So what does Black Americans' health say about health equity in the US? And for me, I think there's still a lack of a comprehensive understanding of health equity and a lack of understanding about Black Americans' health and how social factors influence it. We want to focus on the body. We want to focus on the clinical aspects of it. But there's so much to be done outside of the clinical setting. But that doesn't mean that the clinical setting can't play a role. It also doesn't mean that clinical settings can't exacerbate these issues for Black Americans. We also know that institutions don't work together. We know that the unique lived experience is ignored, and that is when you have people telling their stories and does it support the data, right? It's this hard and fast rule of looking at data and not thinking of the lived experience as a legitimate form of data. We know that the interconnectedness of our lives is ignored, and that goes back to those institutions don't work together. That our social lives, our political lives, our health are sometimes siloed and not looked at all together. And then, of course, in a lot of the research that I've been doing for this, you don't see individuals and communities' voices. You see people talking for them rather than people talking with them. And I think that's a problem when we talk about health equity. So what does all this mean for Black people and health equity? We know that health outcomes fall along racial lines. We know that resources fall along racial lines. We know that gatekeepers of resources fall along racial lines. And I think until this changes, until we start to not have our resources be predicated on whether or not you have the right skin color, there will be no such thing as health equity or health justice. No matter how hard we're working for it, you can't have these amoral features of ourselves can't have these amoral features of ourselves determine who has health and who has well-being. And then lastly, to think about where is bioethics in all this. I am a bioethicist. That's something that I take pride in, but that doesn't mean that I don't recognize the shortcomings of bioethics. I do a lot of reviewing articles on health, medical racism, on racial disparities in health. And a lot of times I see these studies and I see these articles where the white experience is centered, and it will be there like in their research participant list. There'll be a study on health outcomes and social terms of health. And yet when we look at the research participants, they'll be 90 to 95% white. That can't happen if we are really looking at the meaning of health equity and what we can do to pursue health equity. Like I said, experiences are often epistemologically discredited for traditional data. We have to look at people's stories and people's information as legitimate sources of information. Population-focused topics get siloed rather than mainstream. So things like when I talk a lot about Black bioethics or issues that affect Indigenous people or issues that affect Latino people or even transgender bioethics, right? We often see those as separate. Even at our major conferences like ASBH, right? We don't see them as a part of the main program or integrated into the main program. They're often siloed into these smaller talks. And then, you know, one of my pet peeves is that in bioethics, we're still focused on these sort of bread and butter topics. Now, again, these topics are important, like abortion, especially as laws change, things like physician and patient relationships, right? Patient-assisted death. All these issues are important, and I'm not saying that they're not, but we don't look at how those issues also affect Black people and other marginalized populations. And if we don't start to think about these other groups, I'm afraid that bioethics will get less and less relevant to people's lives, and that is not why I became a bioethicist. And then thinking about stories, right? That's something that I am in a bioethics and medical humanities center, and that's the work that I do. And one thing that I've learned from health humanities work over the past few years is that the medical humanists have an emphasis on stories, and they look at them as a means of knowledge and connection. And that's something that I want bioethics to adopt more, to have our work be intertwined with people's stories. And that is a way of centering people. It's a way of hearing them. It's a way of removing that invisibility that some patients feel. It's a way of saying you matter and that we are listening and that we are going to incorporate you, and you tell us what you need. You tell us how to feel about this within our research and within our teaching and within our work. And so really it's to think about, as clinicians, how do you listen more and learn to value people's stories? And I don't mean this long narrative. I mean, just when people tell you what's wrong with them, how do you learn to value that? But then also thinking about what are those practical barriers, those institutional barriers to listening to people? And how do we make sure that patients don't feel invisible? And so lastly, to think about what health equity requires of bioethicists and clinicians. And then here again, by health equity, I mean thinking about health equity in those social resources, equity in those social determinants of health that then contribute to health and well-being. So for first, for bioethicists, put ourselves at the hot seat, that our health equity work, really all of our bioethics works, has to necessarily be different. We have to expand how we teach bioethics, how we research, the information that we deem necessary, but then we also have to sort of level up our empirical work. We have to go beyond our comfort zones. We have to work with people in other departments, which, you know, sometimes we just don't like to do, but we have to learn from these other people that are doing work with other lenses, like in sociology, medical anthropology, those kinds of areas. But then also thinking about how we focus on the sort of justice issues within the work that we normally do. I really think it takes some effort for people who don't specifically work in health equity to think about all these things, but it doesn't take a lot of effort. It's not that hard to think about, if I'm talking about abortion, who else is affected by these issues, rather than just this one mainstream lens that I'm talking about. If I'm talking about AI in healthcare, how do I think about how AI will affect other groups in different ways? And if I don't know how, who can I reach out to talk about this and invite them to publish, invite them to speak, you know, do that kind of work. And then thinking about for clinicians, this is something I always like to think about, and also happy to talk about this in Q&A, how I can fix this or add to it, how I can make it better. But these are just some of the things that I always think about, and some of the ways to think about health equity and how to do this work, especially for Black Americans, that I talk about with my medical students or my MD colleagues. And so I'll just go through a few of these, thinking about how you can include more Black people in your research, how to interrogate your own biases, how to call out colleagues for racist behavior, how to address the elephant in the room, aka racism and racial disparities, talking to your patients, asking them, do you feel like racism or discrimination or lack of social determinants of health affect your health outcomes in any way? Putting them in touch with resources that they need that you can't provide in a clinical setting, but that you have access to other people, you have access to people who can help them. Also being an advocate for institutional policies within your own individual institutions, your own part of the world, that can protect Black people from poor health outcomes because of racial biases. And then also supporting local advocacy groups. There's like Black Mamas Matters Alliance, there's Root, right? Sometimes it's just a matter of doing a talk or giving your time or reading some essays for them. There's small things that they could use your help with, especially because you're MDs and you have this expertise. And then lastly, sometimes it can be as simple as just thinking about your patients' lives and what they go through before you see them and what they go through just to get to your office. Thinking about, do they have transportation, their childcare? Maybe they had to take off of work. Maybe they took some time off and they're not getting paid, so they can come to you and see and get some help. I know in my Houston Medical Center, the largest medical center in the world, we have no free parking to anyone. So patients are also paying money to come see you just to park. They're lesser access to social in terms of health, their structural interpersonal racism that they go through. So it's really about understanding your Black patients as a whole and thinking about all of these issues that they may face just to come and see you for the 15 minutes of time that you have to give them. And how do you make the most of the time that you have with them? But then also, how do you think about, how can I get the most of this time? How do I make sure that I don't then need to send them across the street to this building and over here, or tell them to come back on this next day just to get this test result, right? How do I make the most out of this short time that I have with them, given that they may have had to go through all of these factors just to see you? So in conclusion, The two parts of the social terms of health and anti-Black racism that I spoke about is how anti-Black racism in our social lives creates patients, and that's with environmental injustice, excuse me. But then how, with pain management, how anti-Black racism in our clinical lives prevents people from engaging in their desired social lives. And I like to look at these two aspects because they seem to me to be two sides of the same coin whenever we talk about what is health equity and how anti-Black racism in our social lives and in our clinical lives is just incompatible with what is required of us as health equity advocates. And so ultimately, I want to think about our principles, especially in bioethics. We are very principled. We talk about protection of vulnerable patients. We talk about justice. We talk about beneficence, non-maleficence. We even teach that to our medical students. But when we really think about what is required of us to honor those principles, I question whether all of us doing this work have the courage that our principles require, because it's not something that we just throw away. It's not something we just quiz our students on. It's not something we just throw in a paper to say, oh, look, I did some ethical work on this topic. It's to think about what actions and behaviors and attitudes those principles require of us. And it requires us to be courageous. And then to think about our privileges. How do we use our privileges to contribute to health equity, particularly for the most marginalized people, if we are truly going to say that we have commitments to vulnerable populations? And then lastly, if you liked any of this, this is essentially what my book is. Lots of stories and intertwined with health outcomes and social terms of health. And it is available, and it's specifically written for college students, so it's an easy read. And I am done. Thank you.
Wow, thank you so much, Dr. Ray. That was fascinating and incredibly thought-provoking. I love your work. I also highly recommend your book. I really enjoyed reading it. And I know that our audience really appreciated many aspects of your talk. Several people have upvoted The Color of Law as a great book, and talking about how some of the first examples of housing racism that were mentioned there were right here in the Palo Alto area. So very important for us to be aware of, for those of us who may not be. And also recommendations for the Just Action book by the author of Color of Law, and a link to that.
Right.
Well. So
yeah, Richard Rothstein. It's a great book. Highly recommend.
Yeah, that's great. Several people have commented, thank you for the talk too. So one person is asking about bias in AI, and you had mentioned that, I think, twice in your talk. So I was wondering if you could comment a little bit about the intersection of your themes that you've mentioned and sort of emerging issues in health, healthcare, health research, and bioethics like AI.
Yeah, most of what I'm interested in bias in AI is algorithms that health insurance companies use to say this care is needed and this care is not, or this is care that we'll pay for, this is not. Or, sometimes health insurance will say, start at this care and then you can go this one, and then we'll finally pay for the top tier one if you start at the bottom. And honestly, algorithms in AI give health insurance companies too much room to play doctor. And that's my interest in it is. We already are trying to work with bias in clinicians, just in people. And then now we have to work on it in systems and in machines. But then also despite the bias, I still would prefer clinicians to make those healthcare decisions, the trained ones, than health insurance companies where it's more money focused, or it is more about that door-to-door, like getting people out, getting them in, getting them out. And so, yeah, there's lots of bias in the algorithms that AI choose to implement. But again, AI is still a reflection of bias in our real lives. And so that's the bigger issue too, is I think that if we didn't have biases in healthcare, or it wasn't so prevalent, then maybe it would be slightly less in AI. And so that's most of where my research with AI is going in terms of Black Americans and bias, is how it gives too much control to outside clinical voices, and it reflects the ills of our society.
Right. No, that's a very important point. And I think thinking about how to bring those themes into these discussions about AI is really critical, important. So,
yeah, because it's here, right? It's the future.
Yeah.
It's something we have to think about.
No, that's right. That's right. I wanted to ask you a little bit more about the intersection of what you said about empathy and the limits of empathy. You showed that study about perspective taking and how that improved the ability of the people in that study to have empathy. But you also talked about the limits of empathy. So I was wondering if you could talk a little bit about that and about storytelling and how you think both for clinicians on the day-to-day practice of their clinical work, but also researchers, how we should think about that.
Yeah, I've done a little bit of work and have a slight reputation for not trusting empathy, right? I don't think that's the answer. So, especially a lot of medical humanists will talk about how clinicians need more empathy. And I don't think that's it. I think clinicians have a lot of empathy. I think sometimes medical school can take away a little bit of that and then when they start their residency, because they get a little bit jaded, the systematic inequities, the ways that we treat even the ways we treat physicians can wear them down. They start to see just how much patients need care outside of their setting, and that would make them not patients, right? If they had proper housing, if they had proper meals, if they had access to proper income. And so I think sometimes physicians get really down because they start to just see all of this sickness. And so I don't think empathy is the problem. I think it's how we treat physicians. I think it's how we treat patients, but then also working with psychologists, they tell us that empathy is limited. That empathy, we have more empathy for people who share the same religion as us, who share the same worldview, who look like us, who come from the same economic background, right? Middle-class people have more empathy for middle-class people. Poorer people have more empathy for people with low incomes. Rich have more empathy for rich, right? Our empathy gets employed in so many faulty and inconsistent ways. And so I don't think more empathy is always the answer. I think it can help some, like in that perspective taking study, you saw the gap decrease, but there was still a gap. And that's where I think it sometimes has to go beyond that. It has to go to policy. It has to go to education. It has to be repercussions for these biased actions. It has to be within our systems that we don't allow this. Our policies cannot allow for biases. And so that's where I think it has to go beyond empathy. Because when you say empathy, that means you're focusing on just the clinician. And individual clinicians are some of the problem, not the entirety, but it's also the system that they have to work within. And that is the system that I think needs to also change. It can't just be on clinicians to fix racial disparities in healthcare and health outcomes. It has to be on the institutions that they work within to also make this a priority. So that's why I think empathy is limited, because empathy is an individual issue, whereas the issues in Black Americans' health are not individual, just as much as it's not an individual patient problem.
Yeah, no, that really, I really like the way you said that. And I think that raises a lot of important points. I think the other thing that your book made me think of a little bit is this idea of also witnessing and listening and knowing that maybe there's many clinicians sometimes feel overwhelmed by the scope of disparities and discrimination and harm in the population, that they feel overwhelmed, but at the same time, witnessing, seeing, hearing the patient still has value in the context of providing benefit that's a little bit more tangible than just sort of an empathy as a feeling,
Right. Because I don't doubt that clinicians have empathy, but then also we have to think about who has empathy for them as well. I mean, there's a lot of ways that we don't treat physicians well either. We have residents working too long. They don't get the mental health care that they need, right? They're not paid well, right? And so it's this system breakdown at all levels, at the physician level and at the patient level. And so I think sometimes we want to focus on the quick and easy solutions. And let's focus on the individual solutions while we're also working on the bigger. We can't ignore the individual problems while we're also working on the larger. We can't sacrifice one for the other. We need the Band-Aid over the sprouting water, but also how are we fixing the leak?
No, that's a good metaphor. I know Dr. Salas has a question. Dr. Salas, do you want to ask a question?
Yes, thank you so much for your powerful comments today, Dr. Ray. I have two questions. If we have time, we'll see. The first question is a follow-up to what you were just discussing, to say, are there a couple of specific system-wide or hospital-wide, institution-wide policies that you could mention that would be helpful? Because I think we come across this in a lot of different arenas where we tend to think of a lot of problems at the individual level when really there are structural and systemic problems that are even bigger than those individual problems, and we don't tend to address them. So I was just curious if you have some thoughts on either policy level or other systemic or structural interventions to address racism in healthcare.
Yeah, one that I've seen a lot is actually from California, right? I've seen a lot happen there, particularly with policies trying to work on birthing mortality, right? You've seen a lot of education initiatives. Now, unfortunately, it came from a lot of Black Californian people dying for these initiatives to take place while they were giving birth. For that to happen. But I've seen a lot of education implemented for people that are working with that are basically working L&D, right? That are working with birthing people, that are working with these infants. And so they've seen and California's seen a great decrease in Black infant mortality and Black birthing mortality. It's actually one of the states that's doing a little bit better. I mean, birthing mortality is too high in America in every single state, regardless of race. But California has actually seen a little bit of a decrease in Black birthing mortality. And I think part of that is and then they continue. It's not an education thing, like go this hour lecture and all of a sudden you know how to end Black birthing mortality, right? It's an ongoing thing. And I think, and I do a lot of these one-off lectures, and I always say, like, me being here with you is not enough. Don't think that you are now a health equity person and you know everything about Black Americans' health and you're going to go out there and stop racial disparities from hearing me talk for 60 minutes, right? That's not how that works. Happy to do those kinds of things, but that's not how it works. Also, another sort of roundabout way that I've been looking at different policies is I do a lot of consulting for law firms when they have a medical discrimination case where someone died because of a clinician didn't do something, or those allegedly, right? I don't want to lose my job. Allegedly, they didn't do something. And so I've been looking at a lot of hospital policies, and a lot of the times the breakdown starts at prioritization. Right? Who gets seen when, and it's all about who's believed, right? And a lot of these cases that I'm working on, I say, oh, this kid could still be alive if when he was wheeled in a wheelchair, they just actually believed that he couldn't walk, that he was that fatigued, right? A lot of these people could still be alive if they just believed this woman when she said, I'm pregnant and I'm having some abnormal bleeding. I don't think that's right, right? And they just say, oh yeah, that's normal, go home, right? A lot of it is at the very first point of care. And I think a lot of it, and I saw one hospital system actually from all this, they changed who's their first point of contact in the emergency department. And that had some really, really great effects, that it was an actually medically trained person. It wasn't just a receptionist that was just trying to shuffle papers, get in and out. But then also they they changed their door-to-door policy, right? What's the amount of time that they get in from door they enter, door to leave, and they remove those bonuses and those financial incentives for hospital systems to get those numbers down really low. And so I think a lot of places tie money and promotions and things, these door-to-door policies. And I've seen that have a great effect on patient care when they get rid of that, or they change it up and make it more about the standard of care rather than getting people in and out. And then changing that first point of contact, deciding you need x-rays right away. We need to go ahead and get you straight to an IV. We need to get you straight to an RN or, whoever. So those initial point of contacts, especially in emergency departments, I have seen some great changes.
That's great. I have a question about a lot of what you've been talking about today. I think it's on a lot of people's minds this week, the increases seeing in COVID. And of course, the new booster was approved yesterday.
Right.
There were issues with access to vaccines, access to testing, access to COVID care. There are issues with the no longer public insurance reimbursement for some of these. And so I was wondering if you have any comments about some of the themes you've been talking about and how our audience needs to think about the experiences of Black patients and some of the issues about structural racism you've been talking about in the context of the COVID pandemic.
Yeah, this was something that was very big to me when we started having the initial vaccines, because like I said, again, I'm in Houston, Texas Medical Center. It is a massive city, and it is officially the largest medical center in the world. It's just huge. And thinking about our vaccines were here, It's intimidating to people. You have to pay to park, and it's not cheap. I walk to work. That tells you, and I have privileges, right? It's not a cheap to park here. Also just navigating it. It's trains and buses and shuttles and people, right? So thinking about how do we go where the people are is always a big issue with the COVID vaccines that I think are important. Also this is one where listening to people, but then also getting the data which supports their narratives, and that they're saying, hey, we'll get the vaccine if it's easy for us. Like if it's in front of our church, if it's at a clinic where I can park and not have to pay to park, I'll get it, right? So I've been doing a lot of these journalist interviews during the pandemic, and now that the new vaccine's coming out, and they always keep asking me, why are Black people getting vaccinated? And I'm like, rephrase that question. Black people are getting vaccinated, especially when you make it easier. The data tells us that it's white conservative people who are the ones that are not getting vaccinated. But then also when Black people feel like, hey, you've told me about what this is, you've talked to me, you've listened to my concerns about the vaccine, and told me, actually, you have some misinformation, let me help you. And then they're like, oh, okay, cool, give me the vaccine, right? And so I think that is a good example of how if we listen to people and listen to what they're telling us their concerns are, if we listen to their narratives, and then we actually pair it with other types of data that tells us they are getting vaccinated when these conditions are met, which are very basic conditions, that maybe this narrative that some people have that it's just Black people not getting vaccinated, it's just not accurate. And so a lot of what I'm doing, even in this work, is fighting that misinformation. And you see COVID brought out a lot of concerns about health equity, but also brought out a lot of misinformation about Black Americans' health. It brought out a lot of misinformation about health equity as well. And so, yeah, I'm hoping that with the new vaccine, that's hopefully people have learned their lesson and get rid of that narrative that Black Americans are not getting vaccinated. But then also, like, my mother works for the VA, and she was like, how do we get the vaccine? She started going to like adult day centers. They even had a booth outside of a Walmart, right? Like they were going to places where they knew that their veterans were and their people were, and they would have like huge success rates. They would have need more. They would have to get more vaccines to them because people wanted them, but it was just a matter of access.
Mm-hmm. No, that's really important. Thank you. We had a couple other really good comments in the chat. One quick one, I think our last one will be, Dr. Skeff said there's a controversy as to whether we should include patients' ethnic, and I think he means racial backgrounds, also in presenting to other physicians. Concerns it will trigger bias, but also may help awareness and can guard against bias. Can you comment?
Yeah, I get asked this question every single time that I present. Whoa.
Okay.
That was not in response to the question. I get asked this question, and I love this question, so I thank you. I thought I was gonna not talk about this, and I love it. And it's because I think we have to do a better job of teaching, especially our medical students, what it means to include racial backgrounds on charting, right? That it doesn't correlate to this biological reality, right? And so if we see 35-year-old Black woman, that we don't then go in thinking, oh, well, she must have this and this. These sort of medicines will work for her and this and this. That's my opening story in my book. It's how my doctor thought, oh, you're a Black woman, these medicines will work for you. When they didn't, she was like, well, then I don't know what to do. You're Black, they should have worked for you, right? Like, and we want to prevent that. We don't want that to happen. But if we look at it as, okay, well, it's a possibility that this person is experiencing these racial stressors, or it's a possibility of this sort of intersectionality. She's a Black woman, maybe she has these intersectional experiences with discrimination. Maybe these are some of the lack of social terms of health. So if we look at it more as a social indicator, than rather a biological indicator, then I think that is okay. But if we don't do a better job in that, then I do think there should be legit concerns about including that racial data on charting. But I think it just stems back to how do we prepare people to know what this means when we chart racial data.
No, that's really helpful.
So I do support keeping it there, but changing how we teach it.
Yeah. I know we're at time, but I think we have a few more questions if you're okay staying on for a minute. We have a couple of other questions. Dr. Dunn, I don't know if you want to ask your question directly or if you want me to ask it. Oh, you're muted.
Thank you. I did my camera, but not the mute button. Thank you so much, Dr. Ray, for that incredibly thought-provoking talk. It was wonderful. And I just, speaking about misinformation, that prompted me to ask a little bit about, how you and we can combat folks who don't even want to really hear about the history of these social determinants of health.
Yeah.
And, we can't look at our history with the critical lens. Unfortunately, that's been very discouraged in certain parts of the country. How are we going to solve these problems when maybe half the country doesn't believe that there are problems?
Yeah, I see this on social media a lot. Anytime I post about environmental racism or, I get the here we go, because especially environmental racism, you get it's two-pronged, right? First, I don't believe in climate change, and then I don't believe, or environmental pollutants, and then I don't believe that this can affect racial disparities in health, right? So now it's not to prove to you that, that we're losing rainforests and it's getting hotter and hotter and then colder and colder, and that we're having earthquakes when we shouldn't be having earthquakes, and tornadoes when we shouldn't, right? So it's sort of this two-pronged approach. And honestly, what I've done, one of the things that I've heard about my book and what I try to do is the traditional data, right? I think I have 150 sources for a very small book, because then it's I can't spend the time trying to convince you that, one, we have climate change and that that's a problem. Go read, right? Here's the sources. I'm going to give you all of that information. And then I'm going to show these connections. But I do think that's a part of where we're good at in these scholarly roles, right? Is seeing connections where maybe other people don't. And I think if you can do a solid job of showing that, that's the best you can do. And that's what you have to worry about. And I try to focus on the people that I can help and can reach, right? Whenever I give a public talk, there's always someone in the audience that says, my doctor didn't believe me when I said this. And then because of that, I had to go through all this other testing and I had to go to surgery, right? So I try to focus on those people, because those are people that I want to empower to speak up for themselves, to say to their doctor, hey, something's not right. Those are the ones that I want them to go back and be advocates for their grandmothers, their grandfathers, their uncles, and, things like that. And so I try really hard to show those connections, because I think that can be one way of winning over the skeptics. But again, I'm not naive to think that, they're going to read my book and they'll be like, oh, yep, I get it. There's racial disparities in health and it's caused by these social reasons, especially when you have biological essentialists still pumping out papers, right? Still saying the races are biologically different. And so I try to stay in my lane and only do what I can do and be satisfied with that kind of work.
Thank you. And again, I highly recommend your book as a wonderful book that's also good, as you stated earlier, for many different kinds of audiences in addressing these issues. Well, I want to say thank you. I have many more questions, and so does our audience. And then we're just so grateful that you were able to join us and share your wisdom and expertise with us. I'm going to hand it back to Stephanie to close us off. Dr. Harmon.
Thanks so much. Dr. Ray, thank you so much for joining us and staying a few minutes longer to answer questions. I actually, Dr. Salas put the link to your book in the chat, so for everyone to be able to see that. And so I know for those of us who stuck with us, just a few quick announcements, just reminders. Women in Medicine photo today in person at noon at the Clark Center steps, and then 4:00 virtually. And then next week, join us for Dr. Caroline Berube, who'll be speaking on hemophilia. Thanks, everyone. Have a great Wednesday.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.